Hello, good morning, everyone. So today we are going to talk about Fowler syndrome. We are going to discuss the clinical presentations, the pathophysiology or the neurophysiology behind it. How do you diagnose this patient and what are the treatment options we have? So we start by looking at the clinical presentations, like what are the classical presentation and who are the patients when you suspect to be suffering from Fowler syndrome. So these are the very characteristic features of a Fowler syndrome. So it has to be a young lady and in the third decade usually, and it's almost never seen in the postmenopausal ladies. So there is a reason behind it. We'll discuss it subsequently. There should be no underlying neurological or urological disease. And she comes to you with the retention, and she has more than 1 liter urine in her bladder, and she doesn't have any urgency in spite of such a high residual urine or in spite of such a full bladder. When you remove the catheter, there will be some gripping sensation, difficulty because of the sphincter activity. We'll discuss about that activities in a while. And very strikingly, these patients have an association of with polycystic ovarian syndrome and endometriosis. This can be seen in up to 60 to 70% of the patients suffering from Fowler syndrome. When you see a patient with this background, you start thinking to be a diagnosis of Fowler syndrome. But then to understand basically the neurophysiology and the reason why does it happen, we have to go back till the 1980s when Fowler first described it. So Fowler described it in 1980s, okay, 1985, 1988. There were publications on this Fowler syndrome. And what's the main pathophysiology? If we discuss the pathophysiology, it's mainly because of the increased sphincter electrical activity. So the striated urethral sphincter, there is abnormal EMG activity which is localized to the sphincter and which is responsible for this tension. Now, this abnormal electrical activity which is present in the sphincter, this has some bearing on the detrusor contraction as well. So what does it say? So if we just go back to what the Fowler actually wrote in his publication, then we will just understand it very clearly. The first thing is it's abnormal electrical activity, and this is the abnormal electrical activity which causes the involuntary contraction of the sphincter. The second thing, this activation of the sphincter has a reflex inhibitory effect on the detrusor contraction. First, there is sphincter abnormal activity. The main pathophysiology is there with the sphincters, and this causes abnormal or inhibition of the detrusor contraction. So you might experience a undercontractive detrusor in a urodynamics. You'll appreciate abnormal electrical activity in the EMG tracing as well. So the retention is a secondary effect of the abnormal sphincter contraction. So this is the main neurophysiology behind it. Now, why does it happen? Why it is associated with the polycystic ovarian syndrome? Why is it common in young ladies? Why it's not seen in postmenopausal? So there, Fowler also came with some explanation on this. There is some endocrine reason. There is some hormonal reason for that. And if you look at this, which were described by Fowler, there are two, three important points we should know that will give us clarity on the pathophysiology. So what does it say? This description by Fowler, it says that when a young lady comes with retention, you get a hormonal evaluation as well, and you get to see that there is low levels of progesterone and there might be increased androgens or estrogen. The main problem is with the low levels of progesterone. This progesterone is also responsible for ovulation. So when there is an anovulatory cycle, the progesterone levels are also low. So that anovulatory cycles leads to PCOS, and anovulatory cycles are associated with low progesterone. Now, progesterone has normally an effect on the stabilization of the membranes in general. So when the progesterone level is low, the reduced progesterone leads to reduced stability of the membranes, and this is also affected at the urethral sphincter level. So the membranes in the muscle of the urethral sphincter, they lose their stability and they have abnormal electrical activities. Okay, so it is this abnormal electrical activities which is responsible for the contraction, the sphincter, and this causes reflex inhibition of the detrusor contraction. Now, how have these electrical activities been described? Now, the Fowler further studied it and he described this abnormal electrical activities as complex repetitive discharges, CRDs, and decelerating bursts. We don't have to go into that much of detail to understand the electrophysiology behind it. But then we should know what's wrong in these women and why young women are the main population who are suffering from this Fowler syndrome. And this is all what Fowler described in his study. He included all the different population of female, male, and he found that this is a characteristic finding which is seen in the sphincters of the young women, and it's not found in men with retention as well. Okay. Now, when you are suspecting this with this clinical picture that we discussed and keeping in mind the associated findings of a polycystic ovarian disease, which might be seen in 60-70% of the patients, what are the things we should come? How do you establish a diagnosis? Now, as I said, you definitely will get a urodynamics with an EMG and you'll find abnormal electrical activity in the EMGs as well as underactive detrusor. That might be, may not be present, but that's a reason why patients go into retention without being able to feel the urge of it. Okay. The second thing is if you get a urethral pressure profile, you will understand there is a much elevated urethral pressure and it will be more than 100. The urethral pressure profile, if it's done, it will be highly elevated. Third thing, which is described in the literature, is getting a ultrasound to see the diameter or the thickness of the sphincter. So if the ultrasound is done to looking at the sphincter volume, the sphincter will undergo hypertrophy. Why? Because of the continuous electrical activity within the sphincter continuously does some work. Okay, and this leads to its hypertrophy. So just quickly summarize the things. When there is a young woman with retention and you have ruled out the anatomical causes, you have ruled out the urological and the neurological causes, then the things that should come into your mind is a Fowler syndrome. Now we know what are the clinical presentations. It should be more than 1 liter without any neurological cause, and there should not be any painful retention and associated maybe may not be with a polycystic ovarian disease. You can get a UPP done to find a very high urethral pressure. A sphincter volume assessment with a transvaginal ultrasound, you may find a hypertrophy of the sphincter, and you do an electromyography of the sphincter to find abnormal electrical activities, which is denoted as CPDs. Okay, so these are the different investigations you can do to confirm your diagnosis. It could be a clinical diagnosis as well. Once you are done with this diagnosis, you have to treat the patient. And the standard treatment, which is given in the literature, is the sacral neuromodulation. Regarding the sphincter botulinum injection, there are mixed results, and the exact dose of botulinum to be injected in the sphincter is still under evaluation, and it's not very popular to treat this with a sphincter botulinum. Sacral neuromodulation is the standard option of treatment for a Fowler syndrome. Now, what does it say? How does it work? So this is the latest review that we have available, and it says that the only treatment that has been found to restore voiding in patients with Fowler syndrome is a sacral neuromodulation. This can activate or inhibit the neural reflexes. So basically, that's why it's called modulation, because it can act in different ways. And this sacral neuromodulation not only modulates the local reflexes, it has effect at the level of the forebrain. It has effect at the level of the higher center. How does it work at the higher center? So it is seen that this stimulation will also reinform the sensory part of the brain. How does it do it? So if you see the periaqueductal gray matter, it's a center in the midbrain, and it also receives sensory signals from the lower unit tract. When the sacral neuromodulation is done, this centers also becomes activated in women. So women start feeling the sensation to void, which was absent previously. The component that 1 liter was present without any sensation, that is also treated, and abnormal activity is also relieved. So that's how the sacral neuromodulation is the best treatment and the standard recommendation as per the literature. So we must know this algorithm. When do you suspect a Fowler syndrome? What is the neurophysiology? It's slightly different from DESD. Okay, don't confuse DESD. When the detrusor is also contracting, the sphincter is also contracting, and there is loss of coordination between them. So it's not actually a DESD. It's mainly a sphincter issues, and it's not related to any neurological cause. And how do you diagnose it? What are the clinical associations? You must know about the polycystic ovarian syndrome and endometriosis, which might be present. And what's the endocrine explanation for the association in young women? And how do you manage it with the sacral neuromodulation? So this is the basic thing about Fowler syndrome. Hope you find this useful. Let me know if you have any queries. Thank you.